Today we're going to talk about restraint charting. So the first section on our nonviolent restraint charting is initiation. You must chart your initiation when you start your restraints, and the only other time you're going to chart in this section is when you discontinue your restraints. No other time should you be charting in this section. The next section we have is the orders section. So first thing we're going to chart is our nonviolent restraint alternatives. What did we do to try to prevent the restraints from being put on? You can assess medical needs, reality orientation, comfort measures, environmental changes. Did we move them near the nurse's station? Did we try a sitter? So all of these things should be attempted first before applying restraints. Then we need to chart the patient's response to those alternatives. Did they work or did they not work? Right? Did the behavior change? Is it unchanged? Did it get worse? Did it improve? Next is the provider that we notified. And again, this is a text box just like when you look up a physician's name or put in a nurse's name in here. You just type in a name, hit enter, and it should show you who your physicians are. Then the time that you notified this physician. Now remember, for nonviolent restraints, we should be notifying and getting the order before applying the restraints. With the order section, that will only be charted on once a calendar day. So that means if I put on restraints at 0100 in the morning on a Tuesday, I don't need the restraint reorder till 23:59 on a Wednesday. So we shouldn't be charting in that section, that order section, Q shift, Q2, Q4. It's just once a day. So you just need to look back, make sure that in that calendar day it wasn't charted on, and then get your reorder from there. And again, this is going to be communication between shifts. Now our nonviolent restraint monitoring, which is done Q shift. So this is every shift you should be doing this. So really this should be done twice a day. So first you're going to have your rationale. Why are we using them, right? They interfere or they have cognitive impairment and they interfere with medical devices. The restraint alternatives again. What else did we try as opposed to get them out of the restraints? While they're still in the restraints, did we keep trying those alternatives and see if they still work? Because we should always be trying to get them out of the restraints. Again, the response to the alternatives. Did it get worse? Did it get better? Is it unchanged? The restraint type, and this is important because the restraint order must match what the restraint are. So I know some of the audits that I did, we had soft restraints ordered, but people were charting locked restraints. So it must chart. If they're in a posy belt, a waist belt, it has to. The order says posy belt, it has to be a posy belt, and that's it. If it's soft limb, it has to be soft limb. And then applied to where. So if the order says both wrists and you have both wrists and ankles tied down, you need another order. And then you would chart that in that order section again. So anytime you change an order, it also has to be charted in that order section. And then you need to chart when you got that new order. Next is going to be our education. So we should be educating our patients and the families as to why we're using the restraints. So these are the topics we'd educate on. Next, we talk about who we educated. Patient, family, or no family present, reattempt later. And I know a lot of times, especially for our ICU patients and some of our 9 South patients, is that you can reattempt later because the family's not there, but sometimes the families just don't come in. So you're just going to have to chart what you can. If you were trying to educate the patient, but they, because of their illness or whatever, they weren't able to, then you'll have to address that later. You're going to chart when you educated them, so the date, the time. The patient's response, right? And this is where you could always put other and, patient unable to understand education. So just put something in there as to why, what happened. There you go. Family response. So if you were able to educate the family, did they understand or did they not understand? NCP stands for Nursing Care Plan Intervention. So remember, you have to have a nursing care plan ordered as well with the restraints, but in this is going to be some of the same stuff. So you're going to promote safety, you're going to maintain dignity, comfort, and care. Your expected outcomes is going to be free from injury, and we're going to discontinue it at earliest, right? So these are what we expect to happen. And then the NCP reason not met, partially met. And this is a free text box. So in this one, let's just take a trached, vented patient in the ICU that wants to pull in ICU or 9 South that wants to pull on their trach, right? So patient continues to pull at vent tubing. And that's all you need. The next section is going to be the Q2 monitoring. So this is stuff we do every 2 hours. Now I know a lot of times people like to just do this once and copy and paste it. What I've seen though is I think that you're copying and pasting the whole sections. And what it looks like is that very top section with the initiation is every 2 hours you have something charted in there. You don't need that. Don't do that. You should really only be doing it every 2 hours on this section. So criteria/readiness for discontinuation. Do they meet it? Or do they not meet it, right? So the bottom two are, they're good, you can take the restraints off. That top one that is checked is they still need it. Position change, right? Every 2 hours we should be repositioning our patients. Skin and circulation, so you're looking underneath the restraints, making sure the skin's intact, they're not rubbing their skin off, it's not, their hands or their ankles aren't cold because the restraint's so tight their foot or hand's gonna fall off. Next is going to be our maintain warmth and privacy, right? So we should maintain the dignity of all of our patients. Offer, can they eat? Can they drink? Are they NPO? So that should be charted here. Offer toileting, right? Are they sleeping or do they have a urinary catheter? Hygiene, we're cleaning them up. Call I within reach, you can't answer anything but yes here, so put it there. Even though they're not going to use it sometimes, keep it there. And then the range of motion. And it's not wrong if you only have the upper limbs restrained to do the range of motion on all extremities. I mean, really, this is most of our population between our 2 floors should have range of motion done on all of their extremities. So we removed the restraint, we did the range of motion, and then we reapplied. But just make sure if you're doing the upper extremities and the lower extremities weren't restrained, you don't accidentally click that reapply. You could just click that range of motion section. So this is an upper extremity, we're gonna do all 3, but that lower extremity is not restrained for this patient, so we just do a range of motion. Scrolling on down, that is the last thing. So that is how we should be charting our restraints every single time. If you have any questions, see your nearest manager or educator.